Welcome to our video capsule series discussing treatment-related adverse events with enfortumab vedotin in the management of urothelial carcinoma. In this second chapter, hosted by Dr. Blais, medical oncologist and director of clinical research in thoracic oncology at the CHUM, an adjunct professor at McGill University in Montreal, we discuss the management of skin reactions in response to treatment with enfortumab vedotin, or EV. Dr. Blais interviews Dr. Claveau, a dermatologist specializing in the diagnosis and treatment of melanoma and skin cancers and an associate professor with the Department of Medicine at Laval University. In this chapter, we discuss the types of skin reactions commonly seen with EV, as well as steps for their management. We end with a discussion on the management of these skin reactions with some practical advice for medical oncologists treating urothelial carcinoma.
As I've alluded to before, skin reactions are something new that we're not necessarily used to dealing with when we give enfortumab vedotin. So there's a learning curve, and it's really nice to have dermatologists that have experience and that can help us guide patients. Often they can make the reaction disappear or almost disappear to the point that we can continue treatment with some dose modifications, but that can lead to the success of the continued dosing of enfortumab. So without further ado, I'm going to ask Dr. Claveau to discuss the different skin reactions that we can get with enfortumab with some guidance on how to manage this.
Thank you. So really, we are having a big revolution in oncology right now. For years, we have treated with radiotherapy and chemotherapy, and we had the classic skin reaction, hand and foot syndrome, maculopapular eruption, flexural rashes. But now, with targeted and immunotherapy, we have so many side effects different that it's really great that we have the chance to share the expertise and contribute to the care of our oncologic patient, because really it's important for the quality of life. It has been well documented that it's the number one concern often for the patient, their skin and hair and nails. So for example, with enfortumab vedotin, it's up to 50% and more having skin side effects, and even 15% will have severe side effects. So as you presented in the mechanism of action of enfortumab, it acts on the nectin-4, and this receptor is also is expressed in the skin and in the sweat glands, and we will see a concentration of the medication on the skin, and in the skin, it will give the classic eruption that I will present. As many other treatment, maculopapular eruption, as we see on this slide, is the most frequent, often itchy with dry skin. Of course, since there is a part of chemotherapy in this treatment, we can have hair loss up to 50%. But those are the main side effects that we see, and it's important we talk about the management of this side effect.
So, Dr. Claveau, I never knew about nectin-4 before we talked about enfortumab vedotin. For a dermatologist, is nectin-4 something that's very well known? Is that protein really an important protein for the skin?
We didn't know about it either. There's many different protein in the epidermis, and this nice immunohistochemistry slide is showing that we have a concentration of nectin-4 in the epidermis and the sweat glands, and when the treatment, the antibody attached to nectin-4, we see a concentration of the treatment directly at that site. That's why we get the side effect. It's probably a similar side effect, I suppose, with the cornea. I am not an ophthalmologist, but really it's interesting to understand this.
So it's surprising that we don't have sweat gland abnormalities as a side effect. Is there?
Well, often maculopapular rash, it's not very precise. In clinical trials, we write rash, but we might see a concentration or let's say a predominance of the eruption in the folds, let's say axillary, under the breast, and groin. So the more and more we will use this treatment, we will be able to observe the distribution of the eruptions, and most likely we will see inverse presentation of the maculopapular eruption. So as you could see in this diagram, it's up to 50% of the patient with enfortumab vedotin having a skin reaction. We can have 20% with severe. Sometimes we have pruritus without any skin lesion. It's something we see also with immunotherapy. So if you listen to the patient and they come to see you, especially in the winter time, they will scratch and they will be itchy, very uncomfortable. It's very important in the management. We recommend to decrease the bath and shower time and decrease soap and moisturize. So it's a cornerstone in the management of skin eruption, the skin care, and we'll talk about that later more. But really, as you could see, pruritus, maculopapular eruption are the main side effects we see with this treatment. When we come to severe, often alopecia also is present, and severe skin eruption with chemotherapy is 20%, but with enfortumab up to 50%. So really, we will have to be careful with this treatment. And don't hesitate, as you mentioned, to maybe do a small pause or treat rapidly at the beginning to control and decrease the severity of skin rash to avoid having grade 2 plus grade 3.
Have you noticed that alopecia is the same type of alopecia that we get with chemotherapy? Have you noticed that in your patients?
I would say it's a more diffuse alopecia, like the usual. I cannot tell you it's a different type. Have you observed this on your side since you see a lot of patients, or not really?
Not really, but I was wondering if by the mechanism of action we could expect, something different. I guess it's the toxicity of the hair follicle that makes the hair fall, right?
Yes, I would think it's the chemotherapy part, but when we're talking about immunotherapy, it's really an immune-based alopecia that we see. We call alopecia areata. Sometimes can be alopecia universalis, losing all the hair, even the eyebrows, and it's a different mechanism of action. So when we will use enfortumab in combination with immunotherapy, we may have different pattern of alopecia, a more diffuse type, chemotherapy similar, but also immune type of hair loss we call alopecia areata.
That's very interesting.
Yes. Another point, same thing as compared to targeted therapy and immunotherapy, the skin side effect is really fast in the first cycles. Even when we talk about immunotherapy, it may announce, it may be the first side effects before, let's say, colitis or hepatitis when we talk about immunotherapy. So it's the same with enfortumab. You see the time of onset is often in the first few weeks, so might announce other side effects. So really, we will have to be careful about examine the skin and listen to our patient when they have those complaints.
So is there something of the skin that gets used to the drug? By keeping the same dose, can we expect the skin side effects to decrease with time, or it's just us properly decreasing the dose and adjust to the patient?
It's often the case in targeted therapy. I work a lot in the melanoma field, and we see a lot of the side effects of targeted therapy in the first 3 months. And yes, there's a kind of tolerance. When we get skin side effects for targeted therapy, it's often dry skin, keratoderma, which is like thick palms and soles. And yes, it's more in the first few months. So I would think it's the same with the other eruption with enfortumab. Again, we will gain more experience with time. Management of side effects is key. It's the same with immunotherapy. At the beginning, we had terrible colitis. Now we're more proactive to treat the patient quickly. So for the skin, here we have a nice diagram of various different types of skin eruption, alopecia, maculopapular rash, sometimes predominant in the flexural aspect. The targeted part can give acneiform eruption. Sometimes when it's more severe, we get blisters. So I think one key tricks I can give to the medical oncologist is look for red flags, signs of severity. For us dermatologists, what is a bad skin rash? And if the skin is painful, if you have blisters, if you have involvement of the mucosa associated, so the eye involvement, the mouth, genital mucosa is very important that when you look at the skin, you look for tenderness, blister, and mucosal involvement. Those are signs of severity, and it may announce a more severe eruption, maybe leading even to Steven Johnson or toxic epidermal necrolysis. This is more less severe. This is a more classic of the targeted therapy. We call it acneiform eruption, can be on the face, on the scalp, and this is on the trunk. So really, if you look at this, it's really papules with pustules around the hair follicle. Basically, it looks like acne without the comedons. This is another example of maculopapular eruption, macules and papules, a lot of pruritus. And enfortumab has been associated with dry skin and eczema. And again, I will repeat, it's the same with immunotherapy. So don't hesitate to, especially in the elderly population, look at the legs, you look at the trunk, you will see dry skin, flakiness, and it means the patient needs to moisturize. Men are not very good in moisturizing, women are better. So often it's important to repeat at least to use a moisturizer. For men, maybe a lotion, for lady, a cream after bath or quick shower.
So we're in trouble because urothelial cancers are mostly in men.
I know. So that's why ideally we recommend, dermatologists, we recommend creams, but men don't like when it's too greasy. When you are airy, it's not good. So I think a good moisturizing lotion, we have many on the market right now, and make it simple, okay? Quick bath, quick shower. Right after you use your steroid cream, if it's inflamed, and after a week, you cut down on the steroid cream in a good amount, and then you use your moisturizer. And that's why we really work in collaboration with our pharmacists, with our nurses at our institute to really teach the patient to prevent by starting moisturizing. We have tough, long winter, doesn't finish. So very important to have good, gentle skincare to prevent those side effects.
Do you think that you can prevent the rashes by moisturizing?
Yes, because especially if we have a lot of those skin rashes, is just like dry skin eczema. Eczema starts with dry skin. Maculopapular eruption, if you moisturize well, maybe it will be less severe, maybe will less side effect for the patient. A lot of patients have just pruritus. So really, as a group of dermatologists, we recommend gentle wash, shorter shower and bath, moisturize once or twice a day after shower, and then topical steroid if the eruption arrives. Of course, looking for severity, red flags. As I mentioned, this is a report of Steven Johnson TEN syndrome associated with enfortumab vedotin. It's rare, but it's important for the medical community to be aware that this might be side effects that we will see in the future and detect early, because with these side effects, it's very important we stop the treatment right away.
And this is the type of side effect that you want to be made aware of on the same day, right?
Oh, yes. This is a emergency consult for dermatologists. If we get some blisters like that, often the patient is transferred in our center in the burn unit, because it is really what's going to help the patient to pass through that is really having a specialized bed, good nursing care, avoid the pressure, and look for infection, because those patients, they will be very easy to infect. They will lose their epidermal barrier, and they are prone to develop septicemia and skin infection. So here we have even a skin biopsy showing the destruction of the epidermis associated with enfortumab vedotin in the skin and the sweat glands.
So fortunately, this is very rare. I haven't seen one case so far.
No, this is actually a patient of mine that unfortunately have side effects, Stevens-Johnson syndrome with immunotherapy, anti-PD-1. So again, I repeat the red flags: painful skin lesion, blisters, mucosal involvement. You see the conjunctivitis, you see the mucositis. So this is emergency consult to dermatology. If it's too severe, transfer the patient to burn unit. Emergency consult to ophthalmologist. We have to use moisturizing or lubricants for the eye. And even if it's mucosal involvement, we will have to have a urology and gynae consult, because it can be very severe in the mucosa. I mentioned about the management of the cutaneous side effect. Mario Lacouture is a dermato-oncologist from Memorial Sloan Kettering, has published a lot on the management of skin toxicities. And this is giving us a main overview of the main approach. As I mentioned, education of the patient, avoid strong soap, avoid hot shower, moisturize, and gentle care. Recognize rapidly the skin toxicity. Look at the skin. If it's severe, if you have mucosal involvement in bullous lesion, think about Stevens-Johnson and TEN. And as far as treatment, I mentioned already, repeat, topical steroids. The biggest mistake we do is prescribe a small 30 gram when we have a skin rash covering the whole body. Imagine 30 grams is enough to cover the whole body in one application. So my best trick for oncologists is to use a 150 big jar of moderate strength steroid, like let's say Betaderm, which is the classic one we prescribe all the time, and use a big amount just for 1 or 2 weeks, and it will often make enough for the patient and avoid systemic steroid.
So you think that we don't prescribe enough creams as medical oncologists?
Yes, I teach my medical oncologists, and they will laugh about that. Big jar, Betaderm, V 0.1% cream. My joke to the pharmacist is thin layers don't cure nobody. So big layer of topical steroid, twice a day for a week, and often you will not need systemic corticosteroid. I don't know with enfortumab vedotin if it decreased the efficacy, but for immunotherapy now we know that if we use too much systemic corticosteroid, we will decrease the effect of immunotherapy. So for the skin, we're lucky, we have access. If it's hepatitis and colitis, we don't have the choice, but for the skin, we tend to avoid systemic corticosteroids.
Well, now for digestive colitis with immunotherapy, there are a lot of patients now that we can treat with enteric corticosteroids. So that changes the practice too.
Exactly, because we know if we give more than 10 milligrams a day, we'll decrease the efficacy of immunotherapy. So since we're going in the next few months in the world of using combination immunotherapy anti-PD-1 with enfortumab, I think will be even better to be proactive in treating the skin.
So I'm seeing that there are some agents like pramoxine, camphor, menthol. I don't tend to use that personally. Do you recommend that for itching?
But there is now some combination of a good moisturizer with pramoxine and different companies. I would say it's a second option, let's say, for patient with pruritus without dermatitis, without skin lesion. Moisturizer with pramoxine might be a good option for those patients. But really, if you have a maculopapular eruption, eczematous eruption, I would use topical steroid as my go-to medication. And again, tend to avoid systemic corticosteroid, which often are prescribed too fast.
Don't forget to call your dermatologist.
Yes, I think in most oncology centers all across Quebec and Canada, we have a great collaboration with our colleagues. There's so many skin eruptions right now, different mechanism of action, different skin side effects, not only skin rash, that we could collaborate. Of course, we didn't talk about rare side effects. We know you can have immune bullous disease. We can have granulomatous skin manifestation, paniculitis, which is inflammation of the fat. There's so many. But for general care, I think those tricks we gave you tonight will help.
Thank you for that. That's very insightful.
So really mention that I think the skin, another trick I could say is don't hesitate to examine the skin of your patient once or twice a day because it's very dynamic. We have had a patient recently with immunotherapy side effect and every day was changing. Every day was getting worse and worse. So for those severe side effects, we'll see with enfortumab or any other targeted or immunotherapy, examine the skin everywhere and look for those signs I explained to you, sign of severity, mucosal involvement, blisters, and tenderness. I mentioned already the skin side effects often in the first month of treatment, the first cycles, maybe announcing the other side effects later on.
So some people even consider after a few months to re-increase the dose of enfortumab when things have subsided. I'm not sure I like to do this, but some people think about that.
Yeah, it depends of the severity of the side effect. Will depend also of the response of the patient. Sometimes we will I will call my medical oncologist, ask them to delay the next dose, giving the time to the topical treatment to work and then restart. And this slide showing us side effect in combination with pembrolizumab. So I mentioned that already. I think it will be an addition of two great treatment, giving a synergy to our patient, but may give a synergy of side effects too. We have seen that in other cancers. So I think we'll repeat the same recommendation and be even more proactive because with immunotherapy, we can have also, as I mentioned, immune-related side effects.
Well, it's interesting that you mentioned that there could be an interaction between enfortumab and immunotherapy. This year at ASCO GU, there was a poster that showed that patients that had enfortumab right after immunotherapy had, worse skin rashes, more grade 3, more grade 4s than patients that have had EV without a prior immune checkpoint inhibitor in the recent past. So it's not yet clear how much we have to wait after immune checkpoint inhibitors to have the lowest incidence of the EV-related rash. But, especially if we're going to start using EV with immunotherapy, the combination of both is going to be really challenging.
Yeah, I'm not surprised of that because we see a lot of severe side effects in my institution with a combination of ipilimumab plus nivolumab. This is often the gold standard of treatment of metastatic melanoma in young patients. Same thing being used in renal cancer a lot, even now more and more in lung cancer. So combination of those agents increase the prevalence of side effect, skin side effect, and also the severity. We also have done clinical trials using a combination of targeted therapy plus immunotherapy, and we have seen a lot of skin toxicity. So yes, it's great for the patient, giving better response rate, but toxicity can be increased too.
So do you have general recommendations for the medical oncologist to when to recommend the big bowl of the big jar of steroids versus calling you? When should we not give the jar of steroids, and when should we call you for a consult in the next few days?
But the first, like any other condition in medicine, is try to make a more precise diagnosis. I tried today to explain the main category of skin side effect. If it looks like acne, and you have seen that, let's say, with anti-EGFR targeted therapy for head and neck cancer on the face, let's say with pustules and on the upper trunk, this is not the same as a maculopapular or eczematous eruption. So we know for the acneiform eruption, which is a different presentation, we treat usually with minocycline or doxycycline as we treat for acne. Sometimes we use a mild topical steroid. But really, when we get the classic skin rash, we call maculopapular, or when we have something looking like eczema, dermatitis, then that's where we will use topical steroids. And if you look and you have on the trunk and the limbs, there's no point giving a tiny tube of 30 or even like 60 grams. You will need the big jar. You want to act quickly, get the patient well, and then continue resume your treatment. So I would think the most important is recognize if it's maculopapular, the classic rash, or acneiform. And then I repeat again, make sure you don't have signs of severity like bulla, vesicle, and mucosal involvement, because at this time you will need to call your dermatologist. There are severe skin eruption we call DRESS syndrome. Often the patient is sick with fever. You have your blood tests are affected. Again, this is also a reason to call your dermatologist. So really look for I know it's not your field, but look at the skin and try to see the type of lesion that you see, measure the severity, and then treat appropriately, and don't hesitate to contact your local dermatologist.
I might have another question that's related to the same question, but in the reverse. Are there signs that you look for to indicate that the toxicity is resolving and that we can resume treatment?
Yeah, that's a good point. When we treat appropriately with topical steroids and moisturizer, often the redness will decrease, the pruritus will improve, and with time, it will become a little bit more like bluish gray, and you will see desquamation, peeling. When the skin heals, you have this the recuperation of the skin, and you will see some peeling. So that's a good sign. Often, if you don't develop new active lesion, it's also a good sign. So I would think if you treat appropriately and the patient recuperate, you will see is much more comfortable, feeling better, and the skin gets better to decrease the itchiness.
So for patients that have mucosal involvement, is that longer to recuperate?
Yes, it's rare with the regular maculopapular eruption, you will get mucosal involvement. When you have mucosal involvement, it might, again, you have a differential diagnosis. If it's only the mouth, sometimes can be super infected with herpes simplex. We know those patients are immunosuppressed by decreased neutrophils. If they have a past history of herpes simplex, they may have a mucositis from herpes simplex. But when they have a mucosal involvement, it's more in the field of Steven Johnson. We need to stop the treatment, probably will not be able to resume. And really, we need to have good lubrication of the eye. Often asked ophthalmology, they may give topical steroid drops And the mouth, often I use the oncologic mouth rinse. Also might be a good option, often containing steroids, antifungal, and also anesthetic treatment to make the patient comfortable.
So we've insisted a lot tonight about calling your dermatologist, but I think another very important key point tonight would be to also call your medical oncologist friend. Some of us have a lot of experience with enfortumab. We're really used to decreasing dose, decreasing interval. This agent is being given every week for 3 weeks out of 4, and we can decrease this treatment to every 2 weeks, every 3 weeks based on tolerance. So we don't hesitate to do that. And if we want to give our patients long-term benefit, if there's no use of forcing the doses early and being forced to stop because of a side effect. So if you not sure what to do, there are many medical oncologists that have some experience with enfortumab. So please don't hesitate to call them. You can also talk to your pharmacist. They tend to be on top of dose managing dose modification schemes. So it's a team effort, and by doing this that way, our patient experience will be much better.
It's really my experience, what we've seen in our center. For the moderate to severe skin eruption, often we do a pause. We stop for a few weeks, treat the patient, and then maybe with a smaller dose, we can restart and resume the treatment. If you don't have the severe eruption, Steven Johnson-like, then most likely we'll be able to continue the treatment, and we will see how the patient react. Like many other treatment, we have to make some stop and retry and see how the patient tolerates. So it's really great. We collaborate with our team and medical oncologists. We have 10, 15 dermatologists covering the Centre Hospitalier Universitaire in Quebec City, and it's we're on call. We're changing every day, and it's not rare we get those phone calls from our colleague, because with all those new treatment you're using, we want to help to increase the quality of life of our patients.
So thank you very much for this great discussion. I think I've learned a lot, and I hope you all learned a lot at home listening to this podcast and presentation. Thank you very much for being here.
Thank you. Thank you very much.